Okay, welcome to part 2 of this. Now I've been diagnosed with trigeminal neuralgia, now what, video. And what I want to do is spend some time on what am I observing and what is the treatment therapy, okay? So I want to go through and show you guys what I'm seeing in the T-scan, and that's the sensor that you bite on. And some of you may have already seen some of the videos where you can observe what I'm doing, but you don't know really what it is that I'm doing. So I'm gonna spend a little bit of time on that today, and then we'll add just a couple of more thoughts and close out this part 2. So what you're seeing is a patient who is set up with EMGs and they're biting into a sensor of some sort, right? So to measure how the teeth come together. And so what that allows me to do is see what the muscles are doing while the bite is coming together, okay? And some of those muscles can be hyperactive. Some of those muscles can be so fatigued that they're not firing very much at all. And so both of those tell the operator something. And the reason why the muscles are important, especially in a trigeminal neuralgia diagnosis, where this is neuropathic pain, right? Well, we have a number of studies where patients are being treated with Botox, and the studies seem to be efficacious. And there's not just 1 or 2 studies, there's like 12 or 15. You guys can go to PubMed, you can type on it, Botox treatment for TN, and look at how many studies pop up. If it's really neuropathic pain, why are we treating them with Botox? Because Botox paralyzes muscle, okay? And once the muscle gets paralyzed, hyperactive muscles are allowed to shut off and essentially be quiet and rest. And when we chew or speak with them, they don't recruit as much muscle, so they get some healing time there. Now, I'm not an advocate of Botox. I'm trained to do it. I learned how to do that in my residency. But as a point of putting neurotoxin into the human body, there's a number of reasons why you would do that. And for something that's acute, putting Botox in the muscle and figuring out, does the patient respond to that, is diagnostic, right? It tells you it's more of a muscular thing. But I'm not an advocate for Botox long-term. Like, people shouldn't be on it for years and years and years as a product for symptom control, okay? I want to direct people to ResearchGate. This is like a Facebook community for researchers, and you can go on there, create your own account. You'll need an email to do that, but it's free. And you can go to my profile and you can read some of these DTR and even the trigeminal neuralgia study, which was repeated by Dr. Prafula Thumadi. You can look him up too and read. He got the exact same results I did. So, and I want to be clear about something. Like, I'm not negating that there's not a need for MVD or Gamma Knife. Clearly there are patients that need that. But if it comes back, that might have not been the right choice, or it might not be a good long-term, especially since you have to have this once again, or you only get one and you're done, kind of a thing. And then what if it comes back in 10 years or six years, which I'm seeing frequently in people that contact the office. Like, I had this done and, I was really, really good for, a year or a few years or several years, and now it's come back full force. And so, what are my options? Well, the DTR can be done before or after any of these other procedures. But, it's interesting. I think that patients should be giving a choice. And so if you're watching this, you are an advocate for yourself. Good on you. And we have to rule in or rule out possibilities, right? So one of the things could be, you have a neurovascular compression that's sitting on the nerve and you've got a problem, okay? As we already discussed, this is like 10% of patients. So what are the 90% suffering from? And so we're going to go into that in just a minute. But what would you start out with? I mean, would you start out with brain surgery if this was part of your possibility. So the options for TN are medications. Start off with medications, and medications can be diagnostic too, right? MVD, where we make an incision in your head and we put a piece of Teflon or a pillow or sponge or something in between the nerve and the blood vessel. Okay, so that could be one possibility. You could do the gamma knife, which irradiates the trigeminal nerve ganglia so that it doesn't work properly, and it kind of doesn't report pain very well, and so part of your face is going to be numb. But there are side effects to that too, and some of the neurosurgeons that I've talked to have said that some of those side effects are much worse than the TN, or can be as bad as TN. So it's pretty much a crapshoot. Then there is DTR, right? So maybe it's a TMD, TMJ issue, and that's the reason for your pain. So, and I think other professionals who have looked through a different set of lenses, maybe a neurologist, maybe a general doctor, might look at, especially people who are taking care of these patients, right, day in and day out. We're all looked through the lens of our training, and so. But it's interesting that I really have not had many failures, and there's a handful, and I've probably at this point treated 75, 80 TN patients over a 6 or 7 year period. So there have been some cases that I've done that were compromised, like for example, if you have wisdom teeth, you got to get the wisdom teeth out. That makes this procedure much more difficult. Before I would jump in and do a surgical procedure on my brain, I would check the bite. TMJ is a great chameleon. It looks like a lot of different things, and what a lot of doctors will do is they'll hear a unilateral face pain and they automatically jump to TN. I've seen so many patients that have come through the office that have been misdiagnosed that really have a bite issue that's unilateral, and we have some rules. Let's go over this first. Let's back up. So before we go down that road, let's what is normal? What do we expect in dentistry as far as how the teeth come together? One, the bite should be balanced right and left, 50-50, right? Plus or minus 5%. Generally, the body doesn't care about that. And then the teeth should come together on both sides simultaneously. In other words, we don't want the teeth to hit on one side and then come together, right? Because then there would be this side that would hurt, right? There should be an even distribution of force across all the teeth, and interferences are generally bad. And so that's where we get to disclusion time, is getting rid of the interferences. I will show some examples with the T-scan on what this looks like at some point during the video, so you guys can get an idea of what normal should be. And you may be asking, like, why are more doctors not talking about this? This is can be a real simple fix for a very nasty condition, that nasty diagnosis, and that's true. But dentistry has really abdicated their responsibility for occlusion. Now, there are some docs where occlusion is a focus, but the bite paper itself is concerning. Okay, and that's what most docs use to evaluate the bite or the occlusion. And so scanners aren't going to tell you this information. They can accurately, make a 3D image copy of a tooth, and we can use that information to mill. But the scanners don't consider central nervous system. And this is very, very important. Usually the scanners just use an algorithm to put the teeth together, but it takes into account no input from the CNS, okay? So what do I mean by that? Well, if you have a rock in your shoe, let's just use this analogy. If you have a rock in your shoe and you're walking, and let's say hypothetically you can't take the shoe off, you have to live with the rock that you got, okay? So if you're walking across the parking lot, it's probably irritating, but it's not going to cause a lot of pain. However, if I ask you to walk across town, it could. And what are you going to do to avoid the rock? Your foot is going to go to the right or to the left and try to avoid the rock, right? Well, what's going to happen to your ankle, your knee, your hips, and maybe even your lower back if you have to walk a prolonged period of time and you don't have an even distribution of force across your feet, right? So the mouth behaves the same way. If you have somewhere where you're hitting harder in one tooth or teeth, your jaw is going to compensate to the right and to the left to somehow still bring the teeth together, but avoid whatever rock it is in your to avoid whatever rock is in your mouth. And to be frank, we have 28 rocks, and the only way to balance these out is with a computer. Okay, so the rock in the shoe analogy is an ascending problem. It means it starts at the bottom and it works its way up. Okay, the teeth analogy is it's a descending problem. It starts here and it works its way down. So people that have TN-like symptoms can also suffer from headaches, migraines. My teeth are always really sensitive, okay? Or I can eat, but I get tired quickly. I have to avoid certain foods. If I talk for a long period of time, muscles get tired, I start to hurt. I can have neck pain, I can have shoulder pain. It can be really hard for me to get comfortable before I go to sleep. So I can't sleep on one side, or I have to sleep in my husband's lazy boy chair, and then I can get some sleep. Not good sleep, but I can get some sleep. So it's interesting, once we correct the bite, patients are able to sleep on one pillow or no pillows, depending on how they sleep. They can sleep on both sides. So this is something that you might want to assess and kind of evaluate if you are having some of those symptoms, but you've been diagnosed with TN. Be careful. We have to look more holistically at the body because it's all connected, right? And again, not to dispute what's already in the literature, although there are some glaring things that have not been addressed, right? So, like, for example, when we get to the etiology of TN, either things are moving around in your brain, meaning you weren't born with the blood vessel touching the nerve, so somehow things are moving in your brain. I don't buy that. I don't believe that at all, because what would happen we would have a lot more problems than just the trigeminal nerve, because there's 12 cranial nerves that are in the head, right? And so we don't have an optic neuralgia, we don't have a olfactory neuralgia, and there are things that contact those nerves, all right? And not to mention, but what about the rest of all of the peripheral nerves? The peripheral nerves react differently than cranial nerves, and especially with somebody who plays football or basketball. Let's just take those two. Those are contact sports, rugby, and there are nerves all over the body, and these athletes are doing crazy things with their body. You don't think the nerve is brushing up against other tissues, right? So maybe this explains some, but it certainly doesn't explain all TN diagnoses. My other concern would be through development, the cranial nerves and blood vessels would at some point start touching where they didn't touch before as everything is developing, right? And so it makes you wonder, why aren't we seeing this more in 20-somethings and in teenagers, where the growth rate is the fastest in human life? But that's not what we see. What we see is generally people in their late 40s to mid 50s, females are getting this, right? But it can happen at any age, and it can happen to male or female. So there's some inconsistencies that once you understand some physiology that we have to look at, right? And again, the most simplest thing is let's check the bite. Let's rule that out and see if we get some improvement. Even if you are suffering horribly, and I could say, well, I can give you 50% reduction in your symptoms or symptomology. Would you be interested? Would it need to be 80%? Would it only need to be 20%, right? Before you could start to live life without being bedridden or with the lights off, so that you could facilitate a somewhat normal life, right? So again, the DTR is no medications, no surgery, no anesthesia, no appliance, no TENS, no Botox, and the recovery time is where you never go under. I mean, you drove in here, we're gonna do the adjustments, and you can leave. The only caveat is sometimes the relaxation effect is so great that people take a nap or want to take a nap. So there was just one point I'd like to share in reading some of the literature that I did for the book chapter. There was one neurosurgeon that was pretty much ostracized because he quit doing the MVD procedure. And he said, I have no doubt, one of his quotations was, I have no doubt that patients are getting better, but is it possible it's because we are doing something else when we're messing with the body that is creating a false positive? Meaning, we do the procedure, patients get better, but it's not really because we put a piece of Teflon in between the nerve and the blood vessel. So he got a lot of backlash for that, but it's interesting because, and this is, I have to look up the reference. I'll find it. But it was more like a letter to one of the journals talking about what his experience was, and largely ignored by the community. So then the question becomes, does drilling a hole in the human head alter occlusion? I've come across 3 papers that are inconsistent results. So that might be why we have some inconsistent results with MVD, right? So sometimes when we cut in, there's a big enough change or pressure release in how all of the sutures fit together that the bite does change, okay? So the people that are doing the studies, I don't know, and they're using T-scan, I don't know that any of these people have been trained, and they wouldn't necessarily use it the way I would use it. And I'm willing to work with any neurosurgeon, but I can't get them to even call on a mutual patient. I can't get them to call me back. So that's troublesome, right? I mean, you're trying to do something for the better good of people suffering. And you're like, hey man, let's team up together and let's just go down this path. They don't want to be bothered. And so if there is a neurosurgeon that reaches out that's in Oregon, California, Washington, that would be great, because we could work together and kind of go down this rabbit hole. But I'm seeing a non-surgical method that helps these patients. So I think I've gone over what I wanted to go over, with the exception of 2 things. One, I want to tell you that if you're a patient, you're watching this, you have a voice. You get to vote, right? So if I was suffering from TN, this is the order that I would do things, okay? Get on some medication, and let's see if that's diagnostic, because most people agree that if you respond to certain medications, that it's TN. It's like, okay, we can check that box. And then the next thing that I would do is I would get my bite checked by somebody who is DTR certified, and you can find that on the internet. I'll get a link or put some at the bottom of the video for you guys to look that up. And go in for a consult. Have them put the T-scan in your mouth and see if there's a bite force or a bite timing discrepancy in your bite that could explain what's going on, right? So 80% of the time, the bite's going to be off on the affected side. And what I mean by that is you might be, instead of 50-50, 80-20, and this is the side that hurts because it's coming into contact first, or the muscles are recruiting more on one side. Okay, so that could be one thing. The other thing would be you have a longer disclusion time to the right and to the left. And the best way to kind of check that out is to put your teeth together. Well, you want to do it on a T-scan, but if you're just sitting at home and like, what is he talking about, this T-scan? Put your teeth together. I want you to keep your teeth together, but try to slide to the right, okay? And then come back home. Keep your teeth together, slide to the left. And you can usually do one side easier than the other. And you might be, if you have bilateral TN, which is really rare, you could be locked in on both sides, meaning it's hard to go to the right, hard to go to the left. If you hurt just on the right and it's impossible to go to the right, but you can go to the left, well, that tells us you have a timing issue, right? The bite, many people don't even know that their bite is off. They're just used to it, right? It's like wearing bad shoes. You kind of know it at the beginning and then you get used to it, and then it's not until you're able to take the shoes off at the end of the day that you're like, oh my God, why would I ever wear those again, right? And so the bite kind of works like that. Human beings are not really good at propriocepting how the bite feels, okay, or what there really is. That's why we use a computer. And then if the DTR doesn't work, then we go to the next step, something more dramatic like MVD or gamma knife, okay? But I don't expect too many neurologists to say, hey, he's onto something, let's give that a go and let's try, because the entire careers would be, how do I say this? I wouldn't expect a lot of people to be on board with what I'm saying or what I'm doing, right? Except the results speak for themselves. I wouldn't expect many people to get on board with what I'm saying, just because if someone is learning something new that contradicts their livelihood, are they more or less likely to embrace that change? That's a hard thing to say, but there's a lot of politics involved in this. And I know I've said that before, but it is true. I want to show you guys some scans of how the computer can really kind of elucidate what I'm seeing so that you understand when you make your decision choices in the order that you want to be treated, all right? So here is Betty. You're looking at this display, and so let me show you just in a bare bones. You don't need to know everything that I know to understand this, but right down here between left and right, left being green and the right side being red, that she's 60-40. Remember I said 50-50 plus or minus 5%? Well, she's 60-40, and so the side that's overloaded is the side that she hurts on, okay? So her TN was on the left, all right? And here's Cassidy's video. I've already made a link in part 1 of this video. Her TN was on the left. She started out on the left, okay? And she's 75% to the left and 25% to the right. Okay, here's one. And the colors and the height of these pixels tell us something about force, right? The higher the pixels, the higher the force. So knowing that he's 70-30 pretty much, with 70% to the right, what side do you think his trigeminal neuralgia is on? It's on the right side, okay? And then here is another patient, 73-20 or 73-26, and what side do you think their TN is on? So that's a big deal, right? Where we can correlate this and maybe offer patients something that is not surgical, okay? So this is what I would try first. The adjustments are so minute, nobody gets numb for this. Okay, and so the idea is once the bite is 50-50, you've essentially taken the rock out of the shoe, all the teeth come together evenly, and patients feel better. So that is essentially in a broad spectrum what DTR therapy is.